Hello and welcome to today's Better Care Playbook webinar, made possible through the Seven Foundation Collaborative on strengthening the payer-provider relationship for value-based success in home and community-based palliative care. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's events. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Logan Kelly, Senior Program Officer at the Center for Healthcare Strategies.
Great, thank you so much, Travis, and welcome everyone to today's webinar. We're excited today to explore how successful partnerships between providers and payers can support sustainable and effective home and community-based palliative care programs. Next slide. And before I introduce the presenters, I'll first just provide a quick overview of the Better Care Playbook. The Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. And this includes people with serious illness. The Playbook is a place that you can go to find summaries of the latest research, to find actionable implementation guidance, and also first-person perspectives. And during this webinar, we'll be drawing on some of the resources on the Playbook, and we encourage you to go to the Playbook for more information and to submit resources for Playbook inclusion based on your own work. The Playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading healthcare foundations. Those are Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. Next slide. So on today's webinar, after some brief introductory remarks, we'll hear from 3 leaders at different healthcare organizations who will share their perspectives on opportunities to improve payer-provider collaboration in home and community-based palliative care and the impact of these programs. After we hear from these presenters, a national expert in value-based serious illness care will reflect on these presentations and discuss future trends and opportunities for payers and providers to collaborate on sustainable home and community-based palliative care programs. And then our presenters will answer questions submitted by all of you during the webinar. So again, if you have a question you would like our presenters to answer, please submit it anytime by clicking on that Q&A icon at the bottom of your screen. Next slide. And as you'll see here, we have a really wonderful lineup of speakers today, and I'll fully introduce each one before their respective presentation. Next slide. So we wanted to start just by providing some very quick definitions before we dive into the presentations. First, palliative care aims to provide relief from the symptoms and the stress of serious illness for those millions of individuals who are living with serious illness. And palliative care can be provided in diverse settings, which may include hospitals, nursing facilities, and in homes and communities, and then across the transitions between those settings. Palliative care services are delivered by a trained interdisciplinary team that closely coordinates with other providers. And a common misconception is that palliative care is dependent on patient prognosis when, in fact, these services are delivered based on the needs that a patient has and their goals of care. There's an increased need for these services, which is due to, in part, the overall aging of the US population and the need to deliver services to where people live and to where they want to be. The percentage of homebound older adults has more than doubled in the last 10 years, and meeting the needs of those with serious illness, and particularly in providing patient-centered care that reflects patient preferences, which may be to receive care in their homes, will require increasing access to home-based palliative care. Next slide. And the evidence base for home and community-based palliative care is very strong, and the links on these slides, and which have also just been shared in the chat, all of these links go to studies that are summarized on the Playbook that show some of those strong outcomes that have been seen from home and community-based palliative care programs, which include fewer emergency department and hospital admissions, reduced costs, higher patient satisfaction, and increased access to hospice care. And these programs also help increase the likelihood that people receive care at the end of life that aligns with their own goals. Despite all of these demonstrated outcomes, there can be challenges in building out home-based palliative care programs. They may include figuring out how to target a program to meet the needs of the right patient population that would most benefit, determining the service model and figuring out how to coordinate care across all of those needs, developing a resilient and adaptive care team. And this is where today's webinar will really focus on building a financially stable service. Home and community-based palliative care can take a lot of time and resources and involve non-clinician team members that have not always traditionally been able to be reimbursed for the services that are provided. Value-based payment approaches where care is reimbursed based on the value that it provides rather than the volume of services can offer an opportunity to address some of those barriers and expand access to these services. Next slide. So now I'll turn it over to our first presenter. Dr. Bethany Snyder is the Chief Medical Officer at Hospice Health. She will share how Hospice, a hospice provider, launched community-based palliative care services and share some lessons for providers in sustaining value-based payment arrangements for these services. Bethany, welcome, and I will turn it over to you. Great. And Bethany, I think you might be on mute. Let us know if you're having any trouble accessing. Okay, we're having just a quick technical issue that we'll resolve shortly. And just to make sure that we can move the slides along correctly here.
Okay, perfect. Can you hear me now?
Yes,
excellent.
Wonderful.
Wouldn't be a Zoom meeting without technical difficulties. So it's a pleasure being with you all today. I have the pleasure of speaking on behalf of Hospice Health. And today I'm going to focus on our palliative business line, which has really been our innovation arm over the last few years. So if we go to the next slide, you can kind of see we are a regional provider servicing Kentucky and Indiana. We started as a not-for-profit hospice organization in the late 70s. And what we found over the last 5 to 10 years is we really wanted to focus on strategic partnerships with payers and ACOs to really get at that desire to enhance the quality of life, but at a lower cost of the system and ultimately a better experience for patients and families. So on the next slide, I've really just focused in kind of on our care continuum in the palliative care space. So we do pediatric and adult programs. And over the last 6 years, we've really been trying to determine what is the model that drives the best outcomes in a financially sustainable way. So over the next few moments, I'm going to speak to you just on how we learned into that, what that journey has looked like, and really those lessons that I think you can translate in your discussions with other providers or payers as we all really work together to improve lives for those facing serious illness. So you can see kind of in the center of this continuum, we have two different models, and I'm going to speak to kind of why we've gone in that route and what we've learned that led us to those decisions. So on the next slide, it's really just our journey. And so I don't want to get into the details of this, but just to really emphasize, this is a journey. And I'm sure many of you have walked along this journey with your organizations. And I want to challenge you to continue to be creative and innovative. We made mistakes along the way. We learned a lot about what type of models would be sustainable, what is appealing to a payer or to another partner that's looking to help solve this problem with us. And my hope is in the next few minutes, I'll be able to give you some takeaways that might help you leverage your expertise and your mission for this population and translating that to a successful palliative value-based arrangement. So on the next slide, I wouldn't be a physician if I didn't start really speaking to the experience of care for patients and families and why I believe community-based palliative care is the solution. So we've been running value-based arrangements for the last 6 years with various payers and partners. And what we've been able to demonstrate over that time, as the evidence shows, as they mentioned at the beginning of this webinar, is it's a better experience of care. So when we survey people that have been in our programs, they rate the service very highly. And to me, that's what matters most. The other metric that we follow is impact on their quality of life. This to me speaks volumes, and I don't want us to lose sight of that. Because think about this population with advanced illness. As we're caring for them in a palliative care program, their disease is progressing. Their illness is creating more burden, yet with high quality palliative care in their home setting, we've been able to have a positive impact on their quality of life that's been sustained. And as you can see, even improved over the life of their care in our program. So when we think about cost implications and financial savings, on the next slide, I think this visual speaks for itself. So what we've been able to demonstrate is with an interdisciplinary approach, which I think is critical to the success of a palliative care program, you can have significant savings to the healthcare system. So within our value-based arrangements, when we look at participants that were in the program in the 6 months prior to enrollment and then 6 and 12 months after enrollment, we've been able to cut the cost of acute care spending by over 50%. And as you can see, sustain that for 12 months. I think our ability to do that comes in two kind of innovative approaches that we've leveraged in our palliative care programs to really ensure we're matching the right resource with the right time. And on the next slide, I'm really going to spend some time digging into what those have been for our organization. So first, something we learned along the way is we had to start taking a disease management specific approach. So when we started with our community-based palliative care programs 6 years ago, we didn't really take that specialized patient-specific approach based on their disease and the care plan for that disease. And we weren't able to get the outcomes we wanted. And so that led us to creating these specialty disease management programs that we leverage within the palliative population to ensure that there's specific education and training for patients and families on what to expect, how to anticipate those changes in their condition, but also we added a crisis management component. And I'll speak a little bit more about that in just a minute, but I think being able to prepare families for when the crisis comes and then having resources available to them in that moment is what truly leads to the financial savings and those outcomes that we are seeking for this population. As we all know, those crises don't happen on Wednesday at 2 in the afternoon. They happen on Saturday at 2 in the morning. And so we had to, over time, evolve our model to ensure that we were available to these patients when they needed us. Because when we first went down this road, that wasn't our approach. So we had to really become a 24/7 model, and that we had a co-management arrangement with their PCPs or their specialists so that we could then intervene when they needed that help, ultimately keeping them out of the hospital. The second thing that I must mention is the importance of leveraging technology. So as we all know, financial reimbursement for these types of programs is very limited. And we have been fortunate to get in some value-based arrangements that are financially sustainable. But even still, you're dealing with small margins and limited resources, but a vast territory and a population that you're trying to manage and help them thrive in their home setting. So we've been working with TapCloud, which is just our solution. But the reason I think it's important to consider the type of technology you leverage is it's bigger than just video visits. So while I think that's really important and that helps you add value and frankly, more touches with those patients and families, what we've seen is the enhanced opportunities with technology is what's allowing us to ensure the right resource is matched with the right patient at the right time. And so through our use of technology, we train the families to report in on their symptoms, and that then triages for us what patients need us. Because if you're going based on this idea that they're just going to call you anytime they need you, we're always going to miss opportunities to really address symptoms, optimize their quality of life, and keep them out of the hospital. So I would challenge each and every one of you as you're building these arrangements, think about how can we use technology to enhance the patient care, not as a replacement in our experience. I do think it needs to be a balance of both, but I think there is a place for technology that comes through visits, it comes through secure messaging, it comes through symptom tracking and being able to triage the needs of your patient population. One added benefit that we didn't anticipate through leveraging technology is the impact on the experience of care. And so I'm a physician, so I love to tell stories, but we have patients now that through this platform are sending us pictures of life well lived. And to me, that's success for our program. We get pictures of animals, we get pictures of them on vacation, we get insight into how their lives are going well. And of course, when they need us, which to me is a win for any community-based program. So on this last slide, I just want to really focus in on those takeaways. So what was a huge lesson for me and our leadership team for innovation was we knew there was a palliative population that wasn't being serviced. But what we learned along the way is this population that really needs our community-based services and is the population where we can have impact is actually that 40 to 50% of patients that would be eligible for hospice that are not pursuing hospice, whether it's for treatment-related decisions or because their goals are not in line with a hospice plan of care. Our organization really thought these were going to be hospice patients that had hospice goals and we would catch them sooner. But the reality is this is a sick population with advanced illness that wouldn't traditionally pursue hospice care, and the ability to wrap them with community-based palliative care services allows us to give them a better quality of life. It fills a need in the community, but also at a lower cost to the healthcare system. So I think that's critically important to think about. And as you learn into it for your organizations, what is that population that you're ultimately serving? Because I think that will lead you to make decisions on how you build your model and what it looks like. So for us, as an example, heart and lung patients are the top 2 diagnoses we serve in these value-based arrangements. So that's where that disease management became critically important, because hospice wasn't going to be the solution for that group necessarily. So we needed a way to help manage their needs 24/7, but with limited resources. The second thing that I think is so important is you have to find the right partners. So we have gone in partnerships and it failed because we didn't have aligned incentives or even aligned goals or outcomes for our programs. And so you need to find those payers or those health systems or ACOs where you've got aligned incentives and you're trying to get to the same outcome. Because we've been very fortunate over the last 6 years to find those partners, and that makes this possibility for community-based care much more attainable because they see the value, they know us as a community partner that they've trusted for decades. And so it makes negotiating the right contract and providing the right service for that patient much easier. One last thing I will mention is around how you build your teams and what's really critical in that piece. And for us, the lesson was we had to take a co-management approach. So in the state of Kentucky and Indiana, there are lots of limitations around prescribing, and I'm sure in your states you have similar challenges. But we tried our recommendations or a consultant approach at the beginning of our palliative endeavors, and it didn't work. We could not get the outcomes because we weren't able to help step in and intervene and prevent that ER visit or that hospitalization. And so really this decrease in acute care utilization came through co-management built models that leveraged crisis management. So the tools that we've learned and we've refined over the last 40 years in hospice, we translated those concepts into our community-based model and then incorporated crisis management plans into the home for these patients, and then made sure that we were available to them to intervene right then when they had a symptom issue. And then the last thing, I would be remiss if I didn't mention the interdisciplinary team. They're critical. So you cannot have success in these programs, in our experience, if you aren't addressing social determinants of health. So we ensure that we have social workers and even access to chaplains within our community-based programs, because if you have food insecurity, financial insecurity, transportation challenges, lack of caregiving resources, it doesn't matter what I as a physician do to optimize your condition, it won't make the difference. And so I challenge you to build those models that leverage those additional disciplines. And as you do that and you demonstrate your value, you will have multiple providers and payers coming and knocking on your door because they've seen how you've changed lives for the better and in a unique and innovative way.
Wonderful. Thank you so much, Bethany. I know that I'm sure that there's lots of great questions that are already arising. And if you have questions for Bethany and for other presenters as they're sharing their remarks, please again enter those into the Q&A button. Next, I will introduce Dr. Nancy Gwynn. She is the Medical Director of Clinical Transformation, Population Health at Presbyterian Healthcare Services, and she will describe innovative home and community models of care, as well as payment models to support this care. Welcome, Nancy. Looks like we may be having some, I think we're having some technical challenges related to slide advancement. Nancy, let us know if you would like to move that back to have those slides centrally advanced instead. Great, sorry, we will just be resolving this technical issue, and then we'll make sure that we fix that in our final presentation as well. Thanks all for bearing with us.
Sure. No, my controls disappeared very briefly, so I was unable to chat you. Yeah, I'm back. Hello, everyone, and thank you. And Bethany, thank you, because your whole description of the palliative care services you created was quite pertinent, was really great to hear, but also very pertinent to what I'll be talking about. So first of all, in this original slide, actually, that is a real slide. That is Melanie Van Amsterdam, one of the founders of our Hospital at Home program, speaking to a patient of ours in their home many years ago. So I'm going to speak first about the state of New Mexico and Presbyterian Healthcare Services very briefly. By the way, I think it'd be best, Travis, if you took control back, because the slides are advancing themselves randomly. So if you would go back to the previous slide, once you get control, there you go, perfect. And I'll just ask you to advance as needed. The state of New Mexico has a very lean healthcare payer environment, and that's critical to everything that's happened at Presbyterian and how we've defined and grown services. This state has one of the highest percentage of patients who are paid through government payer sources, such as Medicare and Medicaid, and one of the lowest levels of patients who receive insurance via an employer or some other private payer. So it's a very, very lean healthcare environment, and the percentage of commercial payers is quite low. That defines a lot of what we do. Presbyterian's been around for a long time. It serves 45% of all New Mexicans via 3 different arms. There is a health plan. There's a delivery system with 9 hospitals, many of them critical access in rural areas. We have a lot of clinics spread across the state and a large medical group that's grown over the years. The focus on value-based care at Presbyterian has been evolutionary, of course, but it's driven by the fact that over the years, the institution has become accountable for the total cost of care of more and more patients and members. And so at this point, Presbyterian has the largest managed Medicaid population and the largest Medicare population, Medicare Advantage population in the state. Next slide, please. Bethany, I love seeing your timeline. Here's one also. And this is an evolution over this last, gosh, how has it come to be 16 years? But starting from a base business of a home health agency or home health agencies spread across the state and hospice agencies, all the following services evolved. So originally starting with inpatient palliative care that has expanded over the years. We launched one of the very early hospital at home programs back in 2008 and still oversee that. In 2010, we started our home-based palliative program, also started a house calls program, really focused predominantly on patients who didn't quite qualify for hospital at home, but still really needed some basic services in the home. And then launched an advanced care planning that I won't speak about anymore in this presentation, but has evolved to be used throughout the entire Presbyterian healthcare system in a lot of innovative ways. Our palliative care clinics first kind of popped up in 2013, first in primary care, and have spread over the years. And then in 2015, we actually refocused our house calls program to make it a more advanced illness management program focused on care of our MA patients. I'll discuss that in more depth in just a second. And then the last thing that we've been working on recently has been Presbyterian Health Plan actually was one of the provider or one of the insurers that has worked with Medicare in developing a model of concurrent care for hospice that's available under the particular VBID waiver that's occurred just this year is when it first went live. So we're now for the first time ever able to offer concurrent healthcare services together with hospice to certain patients, which is really exciting. Next slide. Our palliative services, briefly, because they were so well described by Bethany, but we do have our multidisciplinary teams in hospitals, 2 main hospitals in Albuquerque, a rural hospital, and then of course, the advancement of telehealth under the COVID public health emergency has allowed us to be more available across the state. We have clinics now in primary care, enmeshed quite nicely in our oncology services, and then also launched one in our congestive heart failure clinic. And interestingly enough, again, the telehealth changes from COVID really impacted the way we deliver care, and the vast majority of our patient visits are via telehealth. And we found that they're preferred for the convenience of our patients in general, though we do see people in clinic. Our home program is both a specialized nurse-based team inside our home health agency. We're transitioning that a bit to be more of a less formalized program because home health has its own regulatory issues, and turning it to a palliative care team overseen by our palliative physicians with some reimbursement with a monthly per patient per month fee from our health plan for team-based services delivered in the homes for what will probably be about 100 of our Albuquerque area patients. Our teams are interdisciplinary. Our MDs and APNs share a lot of different clinical responsibilities and rotate through different services. We find that works really well for continuity and efficiencies, of course, but also higher satisfaction on the part of the team members. I'm just mentioning a few payment models here because I know that's a critical question from this particular webinar. We have fee-for-service reimbursement from our provider visits. We have episodic care payments, of course, for our home health patients. And then we've developed this new model I mentioned of a monthly payment for certain patients enrolled in our palliative program. Next slide, please. Complete Care. Complete Care cares for the 5 to 10% of our MA members who we believe have the highest disease burden and frailty. And we're offering full services in the home, urgent care, primary care services, continuity, and then hospital and home care when it's needed or when it's valued by those patients in their home. It's very much palliative focused. And one of the key features of this program in my mind is a no discharge model that helps avoid episodic care gaps. Our patients, once they're invited to enroll in the program and enrolled, usually stay with us for the remainder of their life, which can be years, not weeks or months. There is a key feature of the program that we find is particularly successful is a 1 number to call. One of the great stressors for people who are dealing with any form of serious illness and aging in general is navigating our incredibly complicated medical system. And reducing the stresses of navigation and helping them navigate or actually keeping them from requiring to do a lot of navigation is critical for us. So that 1 number to call is a feature that we identify as being very helpful for families and frankly, very helpful for our outcomes. Teams are listed off there. They include both acute care nurses and care management nurses with different skills and different needs for services for patients, community health workers, physicians, APNs, social workers. We have LPNs who help us with things like drawing labs and vaccinations in the home. And then of course, this is a robust practice. So it's really important to include behind it the entire clerical team that's necessary to operate any type of clinical program. There's our censuses listed. So it's about 1,000 patients at this point. We're going to be expanding to 1,300 next year, and we've been staffed for that. We're also adding a pretty robust component of telehealth remote patient monitoring with a different system than Tap Cloud that was Bethany mentioned, but the same idea of facilitating communication in many different ways, and also predictive analytics around how our patients are doing. Our home and clinic programs collaborate around patient care. We do a lot of work with our advanced analytics, including risk stratification of patients throughout our health plan and in our medical system to search for and define possible patients so that we can reach out to them. And what our goal, of course, is to reach them before they end up in a care crisis in the hospital and help get them on the program sooner rather than later. Our outcomes here, there's a range of outcomes listed. There could be more. But first of all, again, evidence over the years due to pretty good cost reporting finally, which took a long time to develop, indicating that their total cost per month is quite a bit lower than equivalent patients. Our hospitalization and readmission rate, of course, is lower, and our ED utilization is lower than a similar population. Our patient and family satisfaction is really very high. And then I was really glad when Bethany talked about the desires that people have to age in place and die at home, because that I think is a key metric for us. And about 85% of our patients die in their homes by their choice. Most of the folks who choose to go into the hospital or other care settings, it is their choice. We will care for people and make sure that we care for them successfully at home as much as possible. And then just a completely different number, our HCC capture rate is very high. So if you think about the need for Medicare Advantage plans to actually demonstrate care, demonstrate that the level of illness of their populations and how that impacts their revenue, that's a critical outcome from their perspective. Next slide. There's a long list of funding sources here. The point is that we've tried everything and we continue to try more things. First of all, there is an understanding implicit within Presbyterian at this point, which has developed over the years, that these services are critical, that the cost savings have been demonstrated. And so we understand that these programs will not break even. And that really changes the entire dynamics around the annual budgeting cycle. We also receive a PMPM from the health plan for certain patients identified as not capitated to our medical group. So that's a monthly payment. And we have fee for service for our palliative services from other payers, which are key for assisting in the funding of those programs. And then I mentioned the new bundled payment model we're working on with our health plan around home palliative services. And then we actually have a separate arm of our clinical group, which works directly on seeing patients in the home for the purpose of capturing disease burden and correctly documenting it. And that is actually the fees that we are paid for that work helps fund our other work. So many different ways we've put funding sources together. Next slide. This list is pulled from the great tools that are available on the website for the Center to Advance Palliative Care. And it's just demonstrating how many metrics that we need to follow for the knowing that our program has high quality that are of value in different ways to payers that you're working on building relationships with. So just a reminder that patients' experience feeds directly into critical metrics for your payers or your hospital systems, right? Something that we would consider critical, which is improving our hospice length of stay for our oncology patients, or trying to assure that they are appropriately receiving chemotherapy during their treatment, but not receiving it when it's not aligned with their goals of care, directly plugs into metrics for a cancer program. So those are just a few examples. Next slide. Lessons learned. This one's about stakeholders. So who are your stakeholders? Who are your referrers? Who are your patients and families? Who do you think your patients and families could be? Who are your hospitals, your community groups, your post-acute care? Understanding who those people are and really assessing their needs helps you define a program that will be of the best possible value to them. a reminder that networking and really high quality patient stories are of high value, as well as the very crisp business plan that you will need to build if you want to either grow services or increase them. Understanding the key needs of those payers is another way to say what I just said above, but really asking them what's their pain points, what's of value to them, understanding what metrics they're trying to address, or what are key concerns can really help you identify how the palliative care services that we all need and want for our patients, our families, ourselves are valued and paid for. Developing innovative care models, which I heard Bethany say at the end of her talk, is so critical to just keep building and designing. And then remembering that revenue to a healthcare plan may be as significant as cost savings. We're trained to demonstrate that palliative care offers cost savings in patient care, but we're less familiar with the idea of identifying how our services are going to increase the revenue via Medicare stars or via other critical and important metrics that of quality that Medicare Advantage and Managed Medicaid plans should be attaining if they can to be able to demonstrate that they're really offering the care that our patients and communities need. I think that's it, if I remember right. I don't think there's a next slide after this.
Wonderful. Thank you so much, Nancy. And next, I'm pleased to introduce Dr. Emily Jaffe. She is the Executive Medical Director at Helion. Welcome, Emily.
Thank you, Logan, and thank you, Nancy. You can go right to the next slide, Travis. So I'm going to try and squeeze two little talks into one little talk today for everyone. I think it's important that we sort of go over the Highmark Health structure so you understand Helion, as well as why we took an overall palliative care strategy in one part of our network, and then how we used insurance incentive programs to drive more members to get palliative care, and then talk a little bit about where we're hoping to go in this program in the future. So if you go to the next slide. Highmark Health is our parent organization, and Helion, the company that I work for, sits at the enterprise level, at the Highmark Health level, where we're driving clinical transformation, and Helion itself works to manage and improve quality in community partners. Highmark Inc. is an insurance company that's owned by Highmark Health that covers all of Pennsylvania, West Virginia, and Delaware, and more recently, Western New York. And Highmark Health also has the Allegheny Health Network, which is a provider network that sits in the western part of Pennsylvania. So Highmark Inc., the insurance company, has more of an integrated relationship with the Allegheny Health Network than with its other provider partners. You can go to the next slide. So when I came to Highmark Health originally, we were looking at palliative care and how could we use the fact that we were an integrated or blended organization to drive more patients or more members into palliative care who needed it. And we did an assessment of the capabilities at the Allegheny Health Network and what it would mean to the Allegheny Health Network to have a more robust palliative care program, and what it would mean to Highmark as the payer to have that resource available to its members. And we put together an integrated business plan, which got approved by our executive leadership, and we began implementation in the second half of 2019. So we just finished out our second year. It really was a ground up program revamp. We used a lot of the CAPC materials to do education around our enterprise, to talk about what would appropriate staffing be. We did a lot of workforce retraining and education, a lot of builds in our EMR and infrastructure changes. And we did have 9 initiatives. One of them was around advanced care planning, which I'll go into more at the next slide. To date, we have exceeded all of our metrics that we laid down and have delivered to the patients, to the providers, and to the payers what we promised in our business plan. So we're excited, even as we rode through COVID, because we had to make some changes and adoptions at that time. Go to the next slide. So rather than walk through the whole strategy, I just thought I could walk you through how we took a blended approach to advanced care planning, completion, and documentation. And when we sat down and thought about it, it really was about, are we doing the right kind of advanced care planning with the right patients? And I say this because we focused a lot on pulse. So we went for the sickest members and patients first. And are we doing that at the right time? So are we using pulse, which is our physician's order for life-sustaining treatment? Were we using it appropriately for the right patients? And were we making it easy for our partners to be able to do the right work? And then how do we make sure that that follows our members and our patients across the care continuum of the Allegheny Health Network? Next slide. And these were the pillars that we built the program on, that we said we needed to have these 5 ingredients for any successful initiative that we had. So as I mentioned earlier, we use the Center to Advance Palliative Care for online training. We've been using it for 2 years. We don't mandate education, and we've, I think, had about 8,000 classes taken voluntarily by our health system. But we really had to get leadership behind us and educate our leadership on what the power of that document was and why it was important to prioritize this, to get it into our medical records, to make sure that we were incenting providers to do advanced directives and reinforcing when the work was done, and make sure that we have the right people around with the right training who can do it in both the primary care offices as well as in the hospitals. We did integrate VINCA into our electronic medical record, which is Epic, so that we had a way to create and curate our advanced directives. We were scanning them into our media file and was having some problems in certain areas, retrieving them when we needed them, as well as making sure that they were filled out correctly, signed and dated. And then we wanted to make sure that people didn't just get advanced directives done when they came into the hospital, but that we were really doing it in their homes and using our care managers in the hospitals and making sure we had clinics and other places where we could get that done. So if you look at the next slide, this is pretty much how we accomplished it by leveraging those pillars that I talked to you about. We built inpatient triggers in the hospital systems, and we set those triggers pretty far down the path. So I would say you could almost say those patients would qualify for hospice who are being triggered. So we wanted to capture the most sickest patients in the when they were in the hospital. And then we also used a outpatient trigger that is in Epic for our owned practices. And we use the Gagny index because it has discrete fields in it. And if a patient has a greater than 10% one-year mortality, we just give a reminder to the primary care physician at the annual wellness visit that they would be appropriate for advanced care planning or a pulse. And we are using VINCA in inpatient and outpatient. We also have a in-home palliative care solution called ECCM at Highmark Inc. And we also use some of the ID and Strat capabilities to put people in that program, and then educated those care managers on how to do advanced care planning. And what we watch as our outcomes is our pulse completion. We're also able to watch, because they're done electronically, how they're filled out and whether we had experience in the past, which I'll talk about in our next slide, where we were pushing advanced directives. This was about 5 or 6 years ago, and we were getting pulse back, basically back on patients that it probably wasn't appropriate and just seeing to do a full intervention. So it was more of a checkbox activity rather than a real discussion with the patient or member. You can go to the next slide. So I'm going to switch gears here a little bit. So I talked to you about a strategy that we took in Western Pennsylvania with our provider network. And now I'm going to talk about what we did with the rest of our provider partners across the Highmark footprint. And I referred to incenting advanced directives. So when this palliative care incentive program was built as part of our inpatient program, my predecessor, Judy Black, had put in place that we wanted to drive volume into our palliative care program and also incent advanced care planning. And after Dr. Black left, Highmark, that incentive program kind of just stayed the way that it was. And about 1.5 years ago, we started to get some calls from our provider partners saying, hey, like you're asking us to do a lot of work on a lot of patients, because we threw a very broad net out when we first built the incentive program. And the people in the incentive program were saying, hey, the thresholds are very high, meaning that they're achieving what we're asking them to achieve, and that we don't really have differentiation among our partners anymore. So I wasn't involved in this before, and someone came to me, being that I'm a palliative care doctor, and said, hey, can you talk to these partners? And it turned out that they were right in what they were saying. And we had, like I said, a very broad net. And I had even gone to a conference where I saw one of the hospitals present, where they said they were getting 100% on our incentive program, and that they were doing advanced care planning or palliative care consults on every Highmark Medicare member that came into their hospital. So I thought, well, maybe we could do better than that. So we brought a group of our participants together, all palliative care specialists from around our footprint. And we said, let's work together to reward providers that can recognize our members that are living with serious illness and make sure that their goals are adjusted and their treatment plans are appropriate, that we agreed that this was our shared mission. And it really was a wonderful experience in that, we really got a lot of input from the clinicians, and we did a lot of education back with our value-based group around what kind of data does a health plan really have? What are we trying to accomplish? What can you really do with claims data, because it is limited to some degree. And so we decided to change the denominator, saying who's the group of members that we're trying to affect based on their diagnosis. And we had 3 general categories. So one was degenerative illnesses such as ALS or dementia. And we put some metrics around that to say you had to have a certain amount of comorbidities, such as aspiration pneumonia or decubitus ulcers, and that you would qualify for this incentive program. We did cancer on staging. And then we did chronic diseases such as CHF or COPD based on utilization patterns. And then the next question that got raised was, is it really all we want is a palliative care consult and an advanced care planning done? Really, this kind of care belongs out in the community, and how do we drive the care out into the community? And so we said that not only did you could either do a palliative care consult for somebody in the hospital, or you could just document advanced directives that you had a goals conversation, so the hospitalist or the rounding attending could do it, that we didn't need a palliative care consult, but that we wanted to see evidence within 2 weeks of discharge that that patient had either been enrolled in hospice, in a palliative care program, that they had been to their PCP's office and advanced care planning, care coordination, or care transitions had been done during that meeting. And we were pretty flexible with it because many of our partners have different palliative care programs, like listening to the talks that we have today. And so we didn't want to, we wanted to encourage them to continue to grow those programs. And so any partner that has their own palliative care program gets credit for enrolling a Highmark member in it. And we have built codes to recognize that that's happening. So we launched this at the beginning of this year, and there is a lag with claims. So we're starting to look at early data that's coming in. And we have noticed that we've cut the volume down by about a third. And we have, looking at the claims, see that we're clearly have sicker patients or members that we're doing on. And we are continuing to bring this group back in the fall. We're going to reach out to them again to look at the data and see how we can refine what we've done. Next slide. So right now, like I told you, what we're watching is the thresholds, that how many people are able to achieve it on our Quality Blue program. And in our hospitals, we're watching the number of pulse are being completed, the percentage of them that are full code, limited, or CMO. And we're watching who's accepting our triggers and satisfying our outcomes. And on the next slide, we just hope to continue to refine. So this is a learning, growing, changing environment and field. And so we will continue to work with the clinical advisory group to refine our incentives over time, keep that task force intact, and also to create more mechanisms in the Allegheny Health Network to drive more volume into the programs that we've built and have wider reach with the members that we touch and patients that we touch. And I believe that's my last slide.
Wonderful. Thank you so much. And I know we've been receiving a lot of wonderful questions already. We've been trying to answer a few that we can as we're going, and we'll be answering more questions during the Q&A. So please continue to submit those questions. We would love to try to answer as many of them as possible. So finally, I'll introduce our last speaker, and I'm really excited to introduce Tori Fields. She is the founder and CEO of Votive Health, and she will respond to the really rich information from these presentations and discuss future trends and opportunities. Welcome, Tori.
Thank you very much for having me today. I apologize. I'm very excited to be able to round out this amazing panel of speakers who are really bringing us into the 21st century of healthcare for people with serious illness. 20 years ago, I read Don Berwick's Crossing the Quality Chasm, a new health system for the 21st century. And we have seen massive amounts of change to help curb the cost and improve the quality to deliver complex treatments for disease-directed treatment and expand primary care delivery, provider attribution, and assignment. And in 2015, only 6 years ago, the Dying in America report, produced by the Institute on Medicine Committee on Approaching Death, identified the quality chasm that we were yet to cross. This was a bold statement about what really happens with people who have complex needs when they are burdened by the complex treatments that are now available to them. The Dying in America report communicated and aggregated the evidence about what people want when people are receiving care for their complex and serious illness and when they're at the end of life. And people want 4 things. They want their pain and symptoms managed. They want to stay in control. They want their caregivers to be supported, and they want more time at home. This translates to a balanced scorecard as aligned incentives for payers and hospital systems and providers alike, focused on the people who really need managed care the most. And what excites me about these panelists today is that you're seeing over the past 6 years, health plans like Highmark and providers like Hospice and hospital systems like Presbyterian are beginning to see pieces of the Affordable Care Act and other areas of payment reform center measurement around the patient. And these mandates and incentives have prompted everyone in the delivery system to this time right now. You see more innovation and dissemination of information about bridging this gap in care for people with complex health conditions who need ongoing support. And we all know how the challenges and dangers people and families face when they receive unwanted and unnecessary hospital and facility care. The highest quality and best managed home care models, like the ones you've heard about today, have the opportunity to achieve the quadruple aim: improve the patient experience and the family experience too, reduce unwanted and unnecessary care, keep people healthier longer through higher quality treatment, and have clinicians who are excited about and understand the value of their work. So why has this taken so long to scale if we have seen and scaled and disseminated this innovation? The first challenge is that it was difficult to find this population of people with ongoing unmanaged symptoms. So once health plans and hospital systems were required to start tracking patients and why they readmit to the hospital, we could have a strong data set of who had a high likelihood of hospitalization. And Medicare Advantage plans needed to start understanding medical complexity, creating a data set of the needs and burdens of this population. Hospital systems and payers were able to improve interoperability, including documentation and reporting requirements about what staff are delivering high quality care. And it's evidenced through requirements around certified electronic medical record systems and joint operating committees for quality improvement. But home, hospice, and other community-based providers who can best support the safe and reliable transition of care from the inpatient hospital setting into the home have largely been left out of these updates and all of these incentives. And this is the next frontier. Historically, most of the beneficiaries of home and community services and have held insurance coverage under Medicare or Medicaid fee-for-service. And as more of the population has been moving to managed Medicare, Medicare Advantage, like Highmark, and more states have expanded managed Medicaid, we need to be able to support home and community-based providers to build the infrastructure and interoperability requirements that Medicare holds hospitals and payers to. Because our systems make it difficult to document team-based care, many home and community-based providers have struggled to document what services they offer and the number of visits delivered by staff that people need at home. Now, these teams have the opportunity through the requirements like encounter documentation, in-home risk assessments, and advanced care planning, that these teams like Hospice and the Presbyterian programs can now show the value of their work to plans, which makes actuaries like me happy. Because these payment requirements are new to home and community providers, care today is highly variable and they get variable outcomes. And so it can be difficult to define or recommend these services to patients. This creates an opportunity to build the evidence for and improve this care through documentation and assessments and through standardization of services like what hospice has been doing. And this helps actuaries and health economists in a health plan to understand what these teams should provide and what payment is needed to deliver the right care. And the access to reliable capitated payment is really necessary to allow care teams to flex their staff and services across a continuum of care that supports a person from point of diagnosis all the way through to their choice of hospice or to survivorship. We are seeing Highmark and CMS build this evidence about outcomes from these partnerships for the first time. So this is really exciting. And in order to scale, we now need to turn our sights to really supporting the necessary infrastructure updates that connect providers in the home and in the community interoperably. And so they have the necessary data to actually understand what patients need and to keep their care teams safe. The future is really exciting if we support this workforce and we're able to grow and scale it through reliable standardization. What excites me about the plans and the health insurance space is that we really see the value of these home and community services, and the measurement attached to that is important for us to know what providers are the right ones and which ones need improvement.
Wonderful. Thank you so much, Tori. So now what we will do is bring all of our presenters on screen, and we'll start doing our best to answer some of the wonderful questions that we've received. So please continue to submit those questions, and we'll get through as many of them as we can. So we've received a few different really thoughtful questions about the relationship between palliative care and hospice care that I would love to hear some responses to. One question was asked about, from a provider perspective, what are the challenges with patients potentially refusing services, palliative care services, because they think they may be hospice by a different name, and what's that rate of uptake and how has that improved over time? And Bethany answered that, but it would be great to hear some broader responses as well. And then we received another question about kind of the importance of framing palliative care as services needed episodically by people with long-term complex medical needs, such as multiple sclerosis, ALS, muscular dystrophy, sickle cell anemia, and other conditions and diagnoses. So I'd welcome some thoughts on both of those questions and how you've grappled with that distinction between palliative care and hospice care, and how you may have seen changes in recent time.
So I'm happy to start that discussion. So as I put in the chat, but I'll expand on it a little bit. Our experience when we went down the palliative care journey was with our existing name, which was Hospice Health. People were terrified that it was just hospice by a different, business line. And so we did some studies out in our community and focus groups, both with patient populations, but also referral sources, just asking if hospice was a barrier, and it was a resounding yes. And so because our brand was so well known as hospice for the last 40 years, it had created this misconception that all we did was hospice. And so that's where we really decided to go down the road of becoming a house of multiple brands. And since we switched to Palliative, so it's a similar play on words, we saw our referrals double with no extensive outreach or marketing efforts, truly just by getting that new name out there. And we've seen our referrals continue to climb and our conversion climbing. And so for us in our community, that was the right thing. The other thing, just to your question around, this idea around palliative care and its need for this chronic population, the one thing I will challenge, and my bias is, palliative care shouldn't be episodic, it should be longitudinal. And so I think with some of the benefits that we've gotten in trouble in our country is we built episodic benefits. And for people with serious illness, that doesn't work. And so I agree, palliative care should come in at the time of diagnosis of many of those conditions that were referenced in the question. And it should be reimbursed in a way that that care level can continue until a different care level is appropriate, such as hospice, or until the time they pass away, if that's the right thing for them. And I think that's my biggest challenge to all of us, is we have to recognize that palliative may always be the right choice for some populations, and for others it's hospice. And it shouldn't be, if you don't get hospice, you don't get anything. And that's really the problem we're trying to solve in our communities, is because we see that limited access, frankly, and equity to high quality services in a home setting if you weren't going down the hospice route.
I think that in some ways, it's about offering the services, and it's about actually helping people understand that the goals are completely different. And Bethany, I think you've taught me this even more over the past couple of months, about the goals are very, very different for people who are looking, who are needing. These are individuals who are not appropriate for home health because they have ongoing needs, as you were saying, Bethany. It can't be episodic because it's regular and ongoing and showing regular decline. And so there are then these folks who have complex or serious conditions, and for one reason or another, they're not eligible for hospice. And we can't prognosticate about some of these individuals. And especially with a rising population of people with cognitive decline, and a lot of people who don't have a lot of caregiver support, so functional decline becomes a challenge. They need something else. Or they might be receiving regular disease-directed treatment. And shouldn't we all be so lucky to receive pain and symptom management while we're receiving aggressive care? That only allows us to receive better, higher quality treatment for a longer period of time, and then help us make a better informed decision about when your goals change and when maybe treatment isn't right for you. But that's really bringing healthcare into the business perspective and helping people understand how to use it and have a good customer experience.
Wonderful. Thank you both. So unless there's anything else that anyone would like to add on that question, Nancy, did you want to jump in there?
Very briefly, one of the reasons that we started our primary care sites for palliative care first was an attempt to find patients who were not disease specific and offer them services at any point in their trajectory that they needed them. So it was a deliberate attempt to step away from most of the predefined models of palliative care. The same is for our complete care program. Many of our patients choose to stay in their homes and under the care of our primary care providers throughout their lives and never move to hospice. And that's fine. We make sure they have as equivalent services as possible.
I can comment also on the name. So we had this inside of AHN, and we do call our palliative care service supportive service. So, even stepping, from hospice to palliative, that we now say supportive. I have mixed feelings about that myself, to be honest. I think it is, something cultural in our country that we need to move towards acceptance, and it is a specialty of medicine. But the goal is to get as many people access as possible, and the name was important for people to feel comfortable with it.
Thank you all so much for speaking to that question. And we've received a few really interesting questions related to cost and related to financing. The first question that came in was if speakers can provide any specifics on cost data for various populations of patients. Is there any data that can give providers a ballpark estimate of what it will cost them to deliver high quality care in an efficient way?
So much of that's unfortunately based on your local environment. So when we speak to people about changes in cost for a population, abstracting from New Mexico to a different location, we speak in percentages, not in dollar amounts. The dollar amounts I shared only pertain to New Mexico, which, as I said, is a really lean environment already and tends to have very low healthcare costs. In terms of how much it costs to stand up and run a team, unfortunately, I don't know any, and I don't know any easy way around at least using some basic tools. And CAPSI, again, Center to Advance Palliative Care, has great tools to build a business plan to at least estimate your population size, who you're going to need to serve them, and then get a very sophisticated back of the envelope estimate for what it will cost to set up a team and run a program. If I were to speak to the costs here in New Mexico, again, it would be have limited pertinence to anywhere else. But it is definitely worth the time invested in at least using some of those great tools around estimating your costs.
I would just flag, if you're an integrated delivery system, there are a couple of papers that have come out that are specific to operational costs for the programs, and they show the difference between operational cost and savings. And those are the SHARP Health System study that was performed by Brian Castle and Kathleen Kerr, and the Kaiser home-based palliative care studies that were produced by Richard Brumley and Susan Ingidinos. Those are, as I shared, there are also others from the VA, but these are all integrated delivery systems. So as Nancy was saying, they could also be hard to translate from integrated delivery system, where it's a little bit more efficient than out in the community.
Yes, I think from the community providers perspective, because we're not integrated, I would challenge providers to do their homework. So you need to build a good pro forma that looks at the discipline composition, what you consider your caseloads, how you're going to leverage technology to make you more efficient, and then, forecast that out. Now that's all guesswork, but it's really important, because I think there was a follow-up question around, well, how do you then know what to go to a payer to ask for? It's that good work. And so we had to figure out with both of our models, kind of what was the cost to us, what did we anticipate the caseloads and the visits, and how are we going to be more lean with technology, and then really calculate that out. And okay, this is our best case scenario, this is our worst case scenario, and don't go less than that. I think what I've experienced being in a community-based organization for as long as I have, we're so used to being generous people, right? We want to give these resources out. A lot of hospices, right, started by giving the care to the community because they saw this need. There was a volunteer-driven philosophy and mission, which is beautiful, and we want to maintain that. But we also have to be a business. And so in order to continue to serve our communities, we still have to cover that cost. And so I think it's really important to partner with obviously your financial experts in the organization. If you're not one like me, I'm obviously not a CFO, but then make sure as you go to negotiate that you can articulate your value, but then that you understand sitting there, what is that kind of bottom dollar amount that you have to get in order to build a sustainable program. And don't forget about volumes, because that's really key, that you build in some kind of minimum volume so that you can meet that financial expectation.
Yeah, I would also add to that so we use CAPSI also for our business plan and those tools, and that led to some credibility. So anybody who's on this phone is passionate about palliative care and in-home care, and we all know the benefits. And but you're going to be speaking with a lot of people who don't really understand and can't really imagine it, right? So going into the home and living that change is what brought us all onto the call today. Being able to say that you have a nationally recognized organization that's using a database, and that this is proven, that this isn't, I always make the joke about that I'm a nice doctor, that this isn't a nice doctor with an idea that's out there, that this is evidence-based, and it's tried and true. You're not reinventing the wheel, you're only just driving transformation.
Wonderful. And we have been trying to share some resources about this evidence base in the chat. If there's any other resources that the speakers would like to share or point to, please feel free to share those with participants as well. And if there's any other additional resources, we may follow up with those after the webinar. And I'll point to the Playbooks collection on home and community-based palliative care as a great central place to see a wide array of that evidence and some brief syntheses of some of those takeaways. So I think second part of this question about financing, the question of how do organizations work with payers to identify the dollar amount of a monthly value-based payment. So I'd welcome any other responses to that, question of getting into the weeds of how this works and any suggestions about navigating developing that partnership.
So obviously the pro forma, as I mentioned, is really critical based on the model you go with. But the other thing I don't want you to lose sight of is you have to make sure identifying the right population. So we had to make sure that we were getting those patients with advanced illness that were also high utilizers. So as you're identifying what population is going to get referred to your programs, that was something we were very thoughtful about as we built the model with the payers or the health systems that we're in those arrangements with. Because you might get this population of people with heart failure or dementia or whatever the diagnosis might be, but if they're not acute care utilizers, it becomes harder and harder for you to demonstrate value, particularly if you're in a shared savings arrangement. And so that's the other thing I wouldn't lose sight of is the creation and the innovation and who's the population is so important for you as a community-based provider as you walk down that contractual route to make sure that you're identifying the right patients, that you have flexibilities built in as you're starting down that road so that you can be nimble and pivot or make changes to how that population is identified. So we were fortunate. We started with one bucket we thought was going to be best. And we realized 6 months in, okay, we're getting a lot of people that are being identified through these analytics that aren't actually right for this program. And we were able to pivot and make sure we narrowed in on the right population. So your data is really important and how you build that so that you can really have a financial model that then hopefully one day you get to benefit from the savings of all the hard and great work that you're doing.
One of the things that I would share, I have spent a lot of time meeting home and community-based providers, trying to understand if they are fitting a standard model. So very similar to what Dr. Jaffe is saying, what is important is to show that it's replicable and it's similar to other things and that it shows results. And so one of the things that is really important and that we often miss is even just very clearly describing what services you provide. And this is a bundle. And so we need to know like the list of those services that you provide and also how often you do them, because that allows us to actually count and then multiply and get a price. And a lot of the time we just have a very weak muscle between us about health plans being a little bit new to what community providers do and not knowing exactly what the price is because we can't define your services. So to start with that, I would say, that's really important. And it helped me understand the value of these services as an analyst and an actuary. And that other part of it is if you have results, even if you don't have a lot of people in your program, it allows health plans to actually find you in their data and determine if you're doing anything that's different from someone else. And that is really powerful in and of itself. And it helps us at insurance companies set the baseline for what you're really doing. And, that makes it a lot easier to really get on the same page.
Wonderful. We've have about 5 minutes left for questions. We'll try to get to a few more. We had a few questions that were focused on Presbyterian. One was tips on identifiers that your analytics team has used to find patients who to enroll early before crises or significant clinical deterioration. And then a second question on how do you balance the no discharge model with the limited resources of a team?
I'll go in opposite order. The key to the complete care program, it is really focused on patients who we define as being the most frail, having the highest level of comorbidities of our Medicare population, top 5 or 10%. And depending on where you are and how large your Medicare Advantage population is, that's not a huge number of people. And so that in itself defines the limits. And it's really important when you're running a program that is as expensive as this program to run, because it's got a provider, staff, clinician, patient ratio that would never be seen in any other care setting, that you confine it to patients who really need it and can benefit from it. And so it's funny, it just doesn't, it should not grow infinitely, because that's a sign that you're actually serving a population that might be better served with a very different program. You know, take, for example, patients who are very high cost due to behavioral health needs. This is not the program for them. And as a matter of fact, we're right now looking at a better way to serve that population within Presbyterian, and I'm part of that planning. So that's what I mean about it's not an infinitely growing program. I think a general palliative care program and a community-based program could grow larger. And the answer is, if there's a need and you've proven value, then you get to grow. If you continue to present robust pro formas or NPVs that indicate that there's value in increasing your staffing and increasing your program, which is just what we did to gain permission to add another 300 patients to the program by adding remote monitoring and 8 FTEs. So that's an example of where even when you think you're done, you keep making pro formas and expanding. Everyone here who does those is like, yep, that's what you do. In terms of tips, boy, I think we've tried 5 or 6 different methods of identifying patients and cobbled together, I don't even know how many versions of what is a good metric for patients. Right now, what we're using is something that's pretty sophisticated, and that's the Johns Hopkins ACG risk stratification tool embedded in Epic that's kind of pouring out data on patients. So unfortunately, that's hard to achieve on a small scale. What we started with, though, were disease states that were aligned with knowing the condition of a patient. So you can make yourself a chart, and there's many trigger tools out there looking at what, CHF class, what, together with what level of functional status, teaching people to start looking at risk score or palliative scores and functional status scores. And you can build a good manual proxy for everything that I'm discussing. And that's what we definitely started out with as a tool. If you can access a RAF score, that's useful also, of course, for your MA population.
Wonderful, thank you so much. And then a question on hospice, interested to know more about the difference between the advanced illness program and the palliative program, and some more details about the crisis management resources that you provide.
Yeah, great question. So I can tell you our advanced illness program came first, and we built that with a health system and a payer, and then another payer based on what they felt like were the needs of their population. So it's interdisciplinary, but it's not provider driven as heavily as our other model. So what we kind of learned into is we had our advanced illness or AIC program going is we needed that co-management piece you heard me speak about earlier. And that's really where the value started to come, and we got those outcomes. So then we launched a similar model, but that's more provider led. So physician, nurse practitioner driven. And could we then get the same outcomes with this model as we were getting in the AIC model? And so that's why we kind of have both going. They're both in value-based arrangements. And so we've obviously already proven the value out of one, and we're trying to see, can we get it here too? Some of that, I think, as we consider for our organization, the nursing shortage is enormous across the country. We have better access to advanced practice nurses, so APRN. So can we leverage them to also do some of the provider work, but to really ensure that we have the staff needed to do these programs? The crisis management piece, I think it's a great thing for you to consider. And there are other programs across the country that have done similar things. So not only do we have specific tools around their disease, so like stoplight tools, education and training, we have a nurse specialist that kind of leads those disease management programs. that when patients have certain kind of triggers, as Nancy had just mentioned, they get a visit from her to kind of wrap around and ensure we've got them trained up on what to do when those crises ensue. Then that last piece for us is we actually put crisis management packs in the home. So based on their disease, there are certain medications that are in that home. So when they call us on Saturday at 2 a.m., it's all there. The provider on call can initiate it, and that's what leads to us keeping out of the hospital. So that's kind of been our approach there, and I would highly recommend it. I think that leads to a ton of success, because if you think about, you've got heart failure, I can't breathe, I'm starting to get fluid building up, you're calling for help. Well, this idea of having to get to a pharmacy, wait a couple hours, or maybe your pharmacy in your community is not open anymore, it doesn't matter what we try to do, right? They're still going to end up in the hospital. And so that's really what led us down that road, especially because we serve a very rural population in addition to our urban market.
Wonderful. Thank you so much. So we just have a few minutes left. Before we wrap up the Q&A, I would just invite any of our presenters, if you'd like to take 30 seconds, if you have any final thoughts on something we might not have touched on, but something that you think is really important that participants take away, or any guidance that you'd like to share with people that are working to design, implement, and refine palliative care programs.
So I'll start. Go ahead.
I was just going to jump in from the perspective of the payer, even though I can switch my hat around a lot and say that, payers are not in the business of providing care, right? And they want, this is an area where you can win all around, right? So you can drive savings and improve care and make life better for the provider. So my advice would be is not to be frightened to lean in to the payer, because not all payers know how to do this, and not all payers have bandwidth within their organizations to innovate and be creative. So I typically, will go to conferences as a provider where there are providers. And my advice to people on the phone who are trying to build a program is network with your larger payers and lean in and do some brainstorming and open sharing about what your challenges are and what you think would be the best thing for your patients and their members.
Wonderful. Thank you. Any other very quick 20 seconds or less final thoughts?
When you meet with your stakeholders, ask them what their pain points are first before you start telling them what it is you think they should fund.
And the last thing I would say is don't be too worried to fail. So I think in our failures and our missteps is where we've actually found creativity and innovation. And so just be ready for that and just make sure you learn from those things. And it'll allow you to build, I think, great programs that we can't even envision today. So I'm excited, as I'm sure all of you all are, about what our future holds.
I think ultimately, if you anchor measurement around the structure, process, outcomes that really support the patient, you get high quality, lower cost, more efficient care in the home and community setting for people with serious illness. So what we can really do is anchor to the patient and remember that the quadruple aim was all about that experience. And we're at a place where everything is now aligned, and we should really take advantage of that and remember that all of us are really in healthcare to improve patient experience.
Wonderful. Well, these are great words to end our webinar on. We'll bring up the slides just for a few last quick items that we wanted to share with everyone. But thank you to everyone who submitted really wonderful, thoughtful questions. And thanks to all of our presenters for sharing your insights with us today. We really appreciated this conversation. Two quick additional resources that might be of interest. We mentioned the Better Care Playbook collection, and I also just wanted to highlight an upcoming event on September 23rd, which is the CAPC Payment Accelerator. For more information and to register, you can go to the website for the Home Centered Care Institute, or HCCI. And again, this information is in the slides, which are available for download on the Playbook site. And then on the next slide, I'll just say that you can browse the playbook for additional studies and implementation tools. And if you have established a promising practice or published on a complex care program, we would welcome you to submit this resource to the playbook by clicking on submit a resource at the playbook's website, which is bettercareplaybook.org. And then on the next slide, we would just love if you can fill out the evaluation survey. We really value your feedback, and it will help us publish content on the playbook that is meeting the needs that you have. And I just wanted to close today by, again, thanking all of our presenters and guests who shared great insights with us, the 7 Foundation Collaborative for making this webinar possible, and everyone who joined us on the webinar today and shared your great questions. Thank you all so much, and have a good day.